Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week it's a conversation about disparities in cancer care with Dr. Tracy Battaglia. Dr. Battaglia is Associate Cancer Center Director for Cancer Care Equity at Yale Cancer Center. Here's Dr. Weiner.
It's really a pleasure to be here with you tonight, and over the course of the weeks ahead, you'll hear me interview a variety of different guests covering a whole range of topics related to cancer, cancer research, cancer treatment. Tonight, we have Dr. Tracy Battaglia. Tracy, welcome this evening. It's really a pleasure to have you.
Thank you so much. It's my pleasure to be here.
So first, could you just tell us a little bit about yourself and your career over the past 20 or 25 years?
Absolutely. So, I think that, as you mentioned, I'm a primary care physician by training and health services researcher. And like all of us, my own lived experience has really shaped the choices of my academic career. And so, as you are well aware, I started my medical career with an interest in health behavior, really, and was a psychology major as an undergraduate. And during that early part of my medical training, I had my own experience with cancer as a survivor of stage 4 Hodgkin's lymphoma. And it was that experience that really sort of motivated me to be interested in oncology as a field. But I also realized that my interest in oncology and cancer was really more sort of in the early stages of prevention and early detection. And so I pursued a career in general medicine, primary care, with an early focus in women's health and breast cancer prevention. And early in my training, I recognized that my care experience was very different than the patients that I was caring for. And so that was what really sort of influenced me to pursue an academic career, really understanding care delivery and just differences in care delivery between different people and populations. And so very early in my career, I focused on cancer disparities and was very sort of driven to try to make my own patients' experiences as positive as my own experiences were. And so that's really how I started in the field of cancer disparities and care delivery.
Well, I know there's been much more to your career beyond that start, and we'll get to that. Maybe we can start by talking a bit about what cancer disparities are. It is known, of course, that there are differences in outcomes for people by race, and that, for example, if you are a 20-year-old Black woman in the United States, you have twice the chance of dying from breast cancer by the time you're 50 compared to a 20-year-old white woman. But that may be the most prominent example of a disparity, and we can talk about why that exists. But there are many, many other disparities as well. And we know that in our country with sometimes great medical care, there are also instances where there just isn't great medical care. So can you comment on the various ways that disparities occur?
So, yeah, absolutely. I want to just sort of take a moment to reflect on the statistic that you just shared about young Black women. And I just want to point out that I've been doing this work for 25 years, and that statistic hasn't changed in the 25 years that I've been doing this work.
It's incredible.
So I think that we should really reflect on that and sort of think about that as we have this conversation, because even though we have an increased recognition of disparities, which are these sort of differences in outcomes by, different groups and populations, we haven't made a whole lot of progress in reducing those differences. And so, maybe we should just talk about what health equity means.
And can I just interrupt for 1 second
Sure.
and ask, isn't it the case also that as cancer care gets more expensive, more complicated, and very often more effective, that those disparities could increase?
Yes, thank you for pointing that out, because I think it helps answer the first question you posed, which is, what are other examples of cancer disparities and inequities? I mean, I think it's this notion that, as care becomes more complex and, really, frankly, sort of tailored to the individual person and the individual cancer type and tumor, as we learn and understand more that, cancer is not one disease, right? It's many, many, many different types of diseases. That complexity makes disparities and inequities more likely. And that is because a major root cause of cancer disparities and inequity is this lack of equal access. And so that goes back to the definition of what health equity is. And health equity is actually when we all have an equal opportunity to be as healthy as possible. So when we're talking about cancer specifically, equity is when everyone has an equal opportunity to prevent cancer, find it early, and get proper treatment and follow-up after treatment is completed. And so with advances in cancer prevention options, early detection options, treatments, and even access to sort of cutting-edge treatments through clinical trials, we have to have equal access to all of those things for equity to be accomplished. And the truth is, the way that our health system is set up, we don't have equal access. So we have to make a conscious effort to think about how to change our healthcare delivery system to ensure everyone has equal access. And that's a very tall order.
So who else, other than people who may be of color, faces disparities in cancer care?
So I think you have to think about different populations and sort of identities. So populations that are at risk are those populations that have historically been marginalized for some reason, much sort of from sort of root causes of structural, sometimes race, but it's also by language and income and gender identity. Where you live matters if you're rural versus in an urban setting. And so we see disparities in inequities when we look at populations through all of those lenses, whether it be white, non-white race, or ethnicity, coming from low income background, not having health insurance or having public health insurance, not speaking English as your primary language, unhoused populations, people sort of who have housing insecurity are more at risk. All the populations that we know don't have access to social support.
It sounds to me like probably half of the U.S. population is at risk.
Well, it's true. Every population and every community has people who are at risk. And so it really depends on where you live. And so, part of the work that I have always done is sort of taking this health equity lens, and which really sort of is sort of asking critical questions around not who is getting care, but who isn't getting care. And that may look very different depending on what community or health system that you're in. So for example, 25 years in Boston, the populations that I worked with in Boston and the health systems that I worked in Boston, the social systems and the public systems in terms of insurance and sort of Medicaid expansion, the populations at risk were different than they are here in Connecticut. And so, I've been here a few months now, and I'm starting to understand the health system, which is very complex. I'm starting to understand sort of the state and sort of the social system. And the populations are a little bit different. And so the approaches need to be tailored and different to address those inequities. And so I think cancer equity really starts with asking the question of who is getting care and who is not. And that really gets at the root cause of inequity.
And it sounds to me like there are just so many reasons for it. So, for example, for somebody who may not have a lot of financial resources and is the single mother of 3 children, that woman is going to, in most cases, be more concerned about getting food on the table for her 3 kids and less concerned about figuring out how to pay for the transportation to get to a doctor's appointment to get her cancer treatment. And yet, on the other hand, there may be problems on the medical side of the equation as well, where certain patient populations just don't get the same attention that others do.
Yeah, I think all those things are true. I often, when I talk about cancer equity, share 2 case studies at the hospital that I worked at, Boston Medical Center. One of a middle-aged white woman in her late 40s who is a professional physician who felt a breast lump and got in and had her mammogram and biopsy within 24 hours and was diagnosed with a stage 1 cancer. And the other patient was a younger 42-year-old woman, Haitian immigrant, non-English speaking, on public health insurance. In fact, was uninsured at the time because she had lost her insurance after she had her last child, suffered housing insecurity after a fire in her home, so was living in a shelter, felt a mass months ago, but, frankly, that wasn't the most pressing issue in her life. So she put off getting care. And it wasn't until 10 months later she was diagnosed with a 10-centimeter stage 3 cancer. That was at my institution where I was seeking care. In fact, that first patient was me. So, I'm providing care to a population. And despite having access to, a large academic medical center with, Medicaid expansion and medical insurance coverage, patients have a lot of barriers getting them into care because cancer, frankly, is not the worst thing that they're dealing with in their life. They're dealing with their 3 kids, getting food on the table and making sure they have safe housing. And so it's those sort of root causes we need to be thinking about as we design our care delivery systems and have these amazing new scientific discoveries that, are helping people live longer, but we're not letting everyone access them equally. And, it's not always just about our healthcare system. It's really about sort of our social system. And I think that the future of cancer equity really has to lie in an intersection between social care and healthcare. And I think there's a movement towards that, but there's a lot of work that we need to continue to do to really realize that.
Well, we're going to take just a brief break at the moment, and we'll be back with Dr. Tracy Battaglia to talk more about how we're going to figure out a way to deliver cancer care to everyone who needs it.
Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. There are many obstacles to face when quitting smoking, as smoking involves the potent drug nicotine. Quitting smoking is a very important lifestyle change, especially for patients undergoing cancer treatment, as it's been shown to positively impact response to treatments, decrease the likelihood that patients will develop second malignancies, and increase rates of survival. Tobacco treatment programs are currently being offered at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital. All treatment components are evidence-based, and patients are treated with FDA-approved first-line medications, as well as smoking cessation counseling that stresses appropriate coping skills. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Good evening again. This is Eric Weiner, and I'm here interviewing Tracy Battaglia. We're talking about cancer care disparities and the challenges that exist, and how we hope to change that in the years ahead. I think it's fair to say, Tracy, that it's going to take a long time before we are able to provide equal access to care to everyone. But along that path, it seems that there's a lot of progress that can be made in a stepwise fashion. Would you agree?
I would agree. I'm excited to change our conversation from talking about the differences and the disparities and what actions we can take to overcome them.
Well, good. So can we talk a little bit about the use of navigation, whether it's nurse navigators or lay navigators, to help with some of the challenges that exist in cancer care for so many people?
Absolutely. So I think we just spent a good few minutes describing the inequities and the differences in care and care delivery. And despite that, and despite the persistence of these inequities, there actually are very few proven interventions that actually overcome those inequities. And so what I'm talking about is, what can we do to intervene to ensure equal access to care, to ensure the same good outcomes for all patients? So how do we do that? Well, there is a very large and scientifically sound base of evidence for the use of patient navigation to improve cancer care delivery across the entire spectrum of cancer care, from cancer screening to early diagnosis and timely quality treatment. Patient navigation is a term that was coined in the 1990s by Dr. Harold Freeman, who was a surgical oncologist in Harlem, where he recognized, as I have recognized in my own practice, that young Black women were dying much more than the white patients he was caring for in Harlem, in large part because they were showing up much later in their disease state. And he asked the question, why is that the case? And it was in large part because they were not accessing care because of all of these barriers to care we talked about before. That cancer wasn't necessarily the priority for the patient because they had all these other social barriers or social drivers to their care, whether it was housing insecurity or food insecurity or employment challenges, insurance challenges, language challenges, transportation, getting to care. All of those things were impeding the access to services. And he designed a program in partnership with the community. And he said, well, who else to better help patients get into our hospital walls, but patients from the community who they know and trust? And so he hired what are now called patient navigators, who are culturally and linguistically congruent with the patient population, to be the liaison between the health system and the patient, to help understand what their specific barriers to care are, and then connect them with community resources to overcome them, whether that be helping them enroll for public insurance, get transportation, support around housing or food insecurity, so that they could deal with those issues as a means to make sure that they were also able to comply with their medical treatment and care. And so, fast forward 20 years now, we have many, very good evidence using randomized clinical trials, which is the best scientific evidence we have, that shows if you insert these patient navigators into the health system to support patients through their care, they are more likely to get into their screening, get a timely diagnosis, and get into timely treatment and have quality treatment and complete that treatment. And ultimately, we know if we can do that, we're going to improve outcomes and start to get to a place where everyone has the opportunity for optimal health.
It's so important, and it's more important than ever before. I know that when I try to access the healthcare system, and I'm about as connected as a person can be, being the cancer center director and having an adequate education and resources. but I find it impossible to navigate the system.
I share that experience.
And if you don't have that inner knowledge, and you, and particularly if there are reasons why you want to run away from the healthcare system to begin with, it's just too easy for that to happen. And you can see how the assistance of a navigator, of someone to just help guide you through the experience, could make such a huge difference.
Yeah, I mean, I think that, in some respects, patient navigation, the fact that we need patient navigation suggests that our health system, is inadequate, right? It's a complex system. And, you add, for you and I who, our medical literacy and health literacy is higher, right? Because we're educated and, care providers ourselves. And we speak the language, and the people we work with are like us, right? So for all of those reasons.
And people want to take care of us.
Absolutely. Right. People, yeah. When I had my cancer diagnosis as a professional, people called me, right? I didn't have to call to get into care. People called me to help me get into care. That was not my patient experience. And so, until we have a just system that supports everyone equally, we're always going to have inequities. And so I don't think health equity or cancer equity work will ever go away, because we're human, right? By nature, we from a social sort of system, we set ourselves up for inequity. And so we always have to be asking that critical question: who in our community right now is not being served? That might look different in 10, 20 years. It might be a different group or population, but there will always be those who are doing better than others. And so we always have to sort of have this critical health equity lens as we approach our work. And so I think that, since COVID and sort of all of sort of the social sort of the unearthing of, what we've always known around social inequity, we've been challenged as a society to do something about it. And so I think that's a good thing. But I don't think we can ever let that guard down. It needs to continue. We're already seeing the pendulum swing in some respects about the focus on health equity and the disinvestment in health equity after there was such a strong investment in health equity post-COVID. We can't let our guard down. And I respect your leadership as a cancer center director in prioritizing this conversation, because it suggests that you recognize that it's important.
And if we can just step away from the professional and into the personal for a second. So you had Hodgkin's disease when you were
20.
in your early 20s, and breast cancer in the last decade. To what extent has that lived experience fueled your desire to pursue this career?
As I sort of started out our conversation, it's our lived experience, it's our stories, it's our history, it's what shapes us, right? And I think that my first cancer experience motivated me to go into this field, and my second cancer experience challenged me to think critically about what we've done to get to where we are and how much further we need to go. So, I mean, for me personally, it's just fueled my desire and sort of commitment to doing this work. But it also helps me understand where we're falling short. And, I see myself as an advocate to continue to ensure that, the leaders of our health systems and our government really prioritize this work, because I can tell you from my own experience that we have a long way to go. We have a long way to go.
And what's really remarkable is that not that cancer care is by any means close to perfect for even those who can get the very best care. But we've made so much progress in the last 3 decades, and the progress feels like it's exponential at this point, with newer drugs being approved at a rate that is really unprecedented, and other kinds of therapies as well. But that's if you can get it, and it's just so critical at this point. So what would you say to someone or to a healthcare system that says, well, this navigation thing sounds okay, but how are we going to afford it? How can we possibly consider covering the costs for navigation?
I think that's easy, right? We can't not afford to do it. We can't not afford to do it. Like, we have to do it because it's going to improve, it's going to save lives. It's actually ultimately going to improve costs because we're going to get people in earlier with an earlier diagnosis so that they have less morbidity and less complications and less complicated treatment regimens. So
yeah, care in the emergency room when you're super sick is not the answer.
That's right.
It's the most expensive approach.
That's right.
Yeah, no, it is really critical. And what would you say to someone who says, this is really horrific what I'm hearing? How can I help? Do you think there are things that non-doctors, non-nurses, people who just have friends with cancer can do to somehow help with this problem of cancer disparities?
Yeah, I think we all have to become advocates in health equity. And I think it starts with asking the difficult questions. Sometimes I am that person in the room that asks the difficult question of who's not here, who's actually not in the room right now. And we're making decisions, but the people who we're making decisions for are not represented. So I think we can, each one of us, sort of hold ourselves accountable in whatever spaces we are, in our communities, in our schools, in our work, with our doctors, as a patient, if you're a provider, as a provider, and ask the question, who's not being served and why? Because we make decisions ourselves and, within the sort of our role as, leaders and administrators that inadvertently leave people out. So I think it just really starts with that first critical question of who's not here and who's not being served and why.
And I guess if when we hear someone has cancer and we know they're, for example, somebody without health insurance who's does not have financial resources or health literacy or education, who's in the LGBTQ plus community, who lives in a rural environment, who for that matter has mental health issues, and of course people who are of color, we have to ask ourselves whether they're going to get adequate cancer care and do our best to help in any way we can.
And that's where patient navigation can come in, for sure.
Dr. Tracy Battaglia is Associate Cancer Center Director for Cancer Care Equity at Yale Cancer Center. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.